Welcome to DocTalks. I'm really excited to have Dr. Andrea Cercek with us today. I'm Manju, the scientific director at Paltown, the nonprofit that supports Colontown. So a little bit about Dr. Cercek. She is an oncologist at the Memorial Sloan Kettering, and she finished her MD from New York Medical College. She is also the section head of colorectal cancer and co-director of the Center for Young Onset Colorectal Cancer and Gastrointestinal Cancers. And her research focus is on the development of new therapies for patients, including molecular-based therapies to improve outcomes for patients with metastatic disease. So we're really excited to have you here with us, and thank you.
Thank you so much for having me. It's my pleasure to be here. So I thought I would talk a little bit about our young onset colorectal cancer program, what we've done with our center, with our program, and then how we're specifically looking at trials and trying to improve outcomes in all of our patients, including patients with early stage or locally advanced disease, in an effort to not only improve their outcome, but also minimize the morbidity of treatment that we have currently available, specifically in rectal cancer. I hope to leave a lot of time at the end for questions, but also feel free to interrupt me at any time. So the incidence of young onset or early onset colorectal cancer is rising, and that's defined at the moment still as cancer under the age of 50. And that's in sharp contrast to what we're seeing in patients over the age of 50, which we attribute the improvement or the decrease in incidence in people over 50 to screening colonoscopies. But in people under the age of 50, it's rising so much so, and it has been this like steady rise, that by the end of this decade, we actually project with computer modeling that the incidence is going to nearly double, and that 1 in 10 of all patients with colon cancer and 1 in 4, so a fourth or 25% of all patients with rectal cancer are going to be under the age of 50. And this rise is actually leading to like a shift and a decrease in general in the incidence of colon cancer in the United States, and really what has prompted the current screening guidelines to be lowered to age 45. So although that's good, I'll kind of show you why we're still not there yet, although that is a significant, improvement. Still, we're catching patients much earlier with the decrease at 45. But the highest rise is actually in the 20 to 30-year-olds who we really are not screening. So the cause is unknown. So there's a lot of culprits. We've been eating more processed foods, junk food, foods high in sugar. We're much more sedentary, as a group in general, sitting in our cars, sitting on our couches, staring at our devices. And then we're ingesting different things than we used to. And this change, I should say, has really been going on since the mid-1990s. And so, what are some of the things? There's definitely more drugs that have been available. Antibiotics are a primary suspect because we're definitely taking much more antibiotics than we used to decades ago. And then just a quick mention of racial disparities. So definitely within the United States, young onset colorectal cancer is rising in all groups, but it remains much more prevalent specifically in African Americans, high incidence in Asian Pacific Islanders, very high incidences in Hispanics, as well as in American Indians and Alaska Natives. The shift is actually interesting in that although in general, African Americans or Blacks have a higher incidence of colon cancer and higher mortality, which has been reported and known for many years. And that applies to people under the age of 50, as well as people over the age of 50 for unknown reasons. Early onset colon cancer specifically is rising much more in non-Hispanic whites and has a higher tendency to be left-sided, whereas cancer in Blacks, including early onset cancer, tends to be more right-sided. And this reason for location is really unknown, but there has been this general shift so that the mortality actually in non-Hispanic whites in rectal cancer in particular is approaching that of African Americans, which is something new that we're not used to seeing. And obviously all of this remains a huge problem in the United States, as well as globally, actually. So one of the main suspects, of course, is the microbiome, and that's the bacterial flora, like sort of the normal gut microenvironment that exists in our intestinal tract, that is meant to be part of our intestinal tract, we believe has shifted. We don't have the evidence for this yet. There's a lot of active research going on in this area, but we know that there are these good bacteria and bad bacteria. And when we have too much of the bad bacteria, actually in mice models, we can see that they lead to these bad bacteria kind of are what are called pro-inflammatory, cause more inflammation, can actually lead to polyp formation and lead to cancer formation. So that's why this is one of the main suspects. And we know with things that we're ingesting, foods, but especially things like medications and especially things like antibiotics, we shift that flora. And we've seen lots of evidence of that outside of this young onset population. And now we're taking a deeper dive into our younger patients. And sorry about that. Oops, there's the emojis that popped up. But when we think about, colon cancer and how it forms, if we believe that it develops the same way that we're used to seeing in our 60 and 70-year-olds, then this might start in really young people, like actually in infancy. So there might be some changes, perhaps that the mother, while pregnant, is ingesting some antibiotics, perhaps due to the way that the baby's actually born. Vaginal delivery exposes the infant to necessary bacteria that without that bacteria, if they're born by C-section, maybe that offsets that balance. And maybe it's even as early on as infancy or early childhood. So it's a very sort of challenging area in terms of risk factor assessment, because it is quite extensive and also, dates so far back. So it's hard for people to say, oh yeah, I took a lot of antibiotics as an infant, or this is, what I was exposed to at birth, or, question things like, were you breastfed? Were you not breastfed? All of those are very important questions that come into play, but are very sort of hard to pinpoint down in this population, but there's a big effort ongoing with that. And then the question is, so there's these changes in our microenvironment, and then how do other factors come into play? Our immunity, or things that affect our immunity adversely, something that we might be exposed to in the environment. Obesity. We ask patients, were you obese? Or when we meet them, they're not obese. In fact, many of them are very fit, but were they obese as an infant or as a young child? Those are all really important things that we need to take a look at. And then things such as diabetes, or what we call this metabolic syndrome, that affects our way of metabolizing certain things and offsets that balance that perhaps might lead to early onset colorectal cancer. So all of these are very high suspects. So what we think is it's this interplay, as I just described. This is just a nice graphic that I like, that sort of looks at our bacteria that might influence the intestinal lining, what affects it, our diet, what are we ingesting, our environment, what have we been exposed to, are we overweight, are we exercising, are we not exercising, are we very sedentary? There have been data published that watching too much TV has been associated with early onset colon cancer, not being outdoors enough, not having enough vitamin D. Is there some sort of genetic or epigenetic predisposition that we don't know about that might be leading to this? And then, of course, as I mentioned, exposure to certain medications and how that plays into this whole process of early onset colon cancer. But what we know, and what's really actually very scary, is that this is a global phenomenon. So this is not unique to the East Coast, where I am, of the US. It's not unique to the United States. It's really occurring all over the world in developing countries, but also in developed countries, and even in countries that are smaller countries. For example, my native country, Slovenia, very small country, very farm to table, very active in general as a population. And yet we're seeing this really significant rise. We're seeing it in Asia, we're seeing it in Australia. So it's happening everywhere. And so there must be some unifying factor behind this that we have not yet identified. So in an answer to this, actually, we opened our Center for Young Onset Colorectal Cancer. So it's a center at Memorial Sloan Kettering dedicated to patients under the age of 50. We established it actually almost 4 years ago now. We were the first center in the world, and I'm happy to say that many other academic centers in the United States and now the world have actually followed suit, which is really fantastic and really important. And we helped them establish those centers. And the idea here was that we were seeing more and more of young patients. The patients had different needs than what we were used to taking care of in our patients who were 60 and 70. And that's not to say that treatment, toxicity of treatment, financial toxicity, family dynamics are not important when you're 60 or 70, but it is very different when you're in your 20s, just starting your life, or in your 40s, taking care of your young children, taking care of potentially even aging parents, having to deal with the burden of going through treatment. And so we really noted, actually, with the help of many patient advocacy reports, actually, that were really influential, where we noted that patients really felt sort of at a loss after treatment, and that we felt that if we were able to offer early intervention with ancillary support services like social work, everyone in our center meets our social worker at least once. Many continue their care with her. Some are referred out to other support groups. Some just don't need such support, and others we refer to psychiatry and psychology. We have early fertility, which we noted is very critical for our patients, and others have since published this data that really, even a conversation, even if they have advanced disease, at least a conversation, an ability to decide whether or not they would want to have a child, even if they meant they weren't going to live to meet that child, was very critical for our patients. And so that's something that's offered early on for our patients. Sexual health is critical. It is very, very important in our patients with rectal cancer in particular, because of all the toxicity from treatment, from the radiation and from surgery, but all of our patients in general, even men who undergo surgery. So we introduce sexual health early on. Integrative medicine, many of our patients are interested in doing something for themselves in addition to the chemotherapy. Can I take vitamins? Can I do acupuncture? So we have a fantastic integrative medicine department that offers those services that I find critical. And of course, the rest of the medical care remains as it would have been in terms of the referrals to medical oncology or surgery, or our colleagues in radiation oncology. And then our second, and equally, I think, as important objective of our center was to establish a clinical database. So a prospective database of all of our patients that come through the door, enroll in our program. We have a biospecimen repository, so we collect things like stool for that microbiome analysis that I mentioned. We have a very lengthy but important risk factor questionnaire from infancy into early adulthood in terms of potential things that they were exposed to. We collect blood as well as tumor tissue for analysis. And just to give you an example, this is actually our team. Larry on the left is our fantastic project manager, without whom we would not exist. And he meets the patients early on, introduces them with an email and an information session, and helps us manage the database. Hadley is the second from the left. She is our social worker who I mentioned meets all of our patients. That's me in the middle. And then my co-director, Dr. Mendelson, is a gastroenterologist. And Asha is one of our research coordinators, and we've since expanded to other research coordinators, and are hiring a nurse practitioner as well. So this is just an example of our patients treated. Unfortunately, we have no shortage of patients. We started out with 201 patients in 2018, and are now up to 519. These are new patients under the age of 50 that walk through the door at MSK. So these are not existing patients that are part of our center. These are brand new people that we meet in 2021, despite COVID. So really a large number of patients. And so just to give you a little bit of a sense of what early onset colorectal cancer is, and one of our first questions, or really important research questions, is what are we exactly dealing with? Is this a totally new disease? Is this something that we're not used to seeing? Or is this simply a disease that used to happen in people in their 60s and 70s that's now shifting all over the world to happen younger and younger and younger? I had two 15-year-olds this year. Pediatrics called me and said, this is not our disease. Please help take care of these patients. So I treated them with the help of our pediatrics department, which is not something that we were used to seeing. and more of this is happening. So the question really, the crux of the question, I believe, was new disease, something different, or same disease and shifting, and how do we better, treat it, were the questions that came after that. So what do we know about this disease? So initially, the reports were really alarming. The large majority of these patients presented with late-stage disease, and the thoughts were, well, this is more aggressive, this is a different disease, this is something that we're not used to seeing. But remember, these are patients that are not being screened. And a lot of patients, not as many as we should be, but a lot of our patients over the age of 50 are thankfully detected and diagnosed with those screening colonoscopies. So they might have a stage 1 cancer, they might have a stage 2 cancer that was caught early. And that's how they're detected. These patients, many of them just didn't undergo screening because it was not recommended. But additionally, what we learned actually from the Colorectal Cancer Alliance, and the reference dropped off, unfortunately, but this was their analysis, their survey, is that a large majority of these patients saw at least 2 physicians prior to being diagnosed. They were kind of dismissed as, oh, this is hemorrhoids, this is, nothing, just rectal bleeding, you're fine. It didn't occur to anyone to refer them for that screening colonoscopy. And then what we learned also is that many of our young patients actually themselves deferred going to a doctor. They were busy, they had exams, they had a job, they had a family to take care of. So they didn't undergo screening for 6-7 months, or it didn't see a doctor rather for many months, minimizing their symptoms, minimizing their rectal bleeding. So a really important thing that we want to spread to the general public is, if you have persistent symptoms, go see a doctor. This could be happening even if you're in your 30s. And then what we looked at, and others have looked at as well, is this a hereditary cancer? Is this something that we're used to seeing, Lynch syndrome, familial polyposis, adenomatous polyposis, that we're just seeing more of for whatever reason. And in fact, this is not the case. 60% or more of these were random, or what we call sporadic, where they don't even have a family history. So their parents are in their 50s, 60s, they're completely fine, not even a polyp on their screening colonoscopies. And here is their 30-year-old with colon cancer for completely unknown reasons, completely sporadic or random. So as I mentioned, our first question was really to take a good look at this. So we had a lot of patients. We had nearly 1,500 patients, half under the age of 50, half over the age of 50. And we wanted to look at their tumor biology. We know the molecular signature of colorectal cancer very well. We know that left-sided tumors look different than right-sided tumors. This has been reported, this is established. We actually treat them differently for all comers. And so our question was, if we can take a very good look at the molecular signature, but have complete clinical annotation, including not only the age of the patients, but the whole treatment history, the presenting symptoms, the location of their tumor, and then look at the molecular genetics. With that in mind, do we still see any differences? Because earlier reports were saying, oh, it looks different, but they didn't have the full clinical annotation. And we know that if we take a group of 60-year-olds and we compare them, they may look different, because those that have a right-sided tumor will look different than those with a left-sided tumor. So that was really, really important to take a look at. So what we saw is that more patients that were younger, under the age of 50, had rectal tumors. And we were not the first to report this. This was known, and we saw this as well. Why this is, we don't know, but this was definitely the case for us. Because of that, more young patients presented with rectal bleeding because of the tumor location. If it's in the rectum, patients bleed more, whereas if it's on the right side, they tend to have more anemia. And that's what we saw in our groups exactly. And then when we looked at the actual genetics, there was no difference. So left to left, the tumors in, even our very young cohort and our patients over the age of 50, even in their 70s and 80s, no differences when comparing left-sided to left-sided or right-sided to right-sided, suggesting really to us that in this population, these were predominantly stage 4 metastatic tumors. When you truly compare and have a clean comparison, it really looks like the same disease. So there really was no difference. And although we all wanted to find something, we wanted to have this difference, we believe that this was really explained by this general shift in incidence. Something is changing in our intestinal tract that's just causing us to make these same tumors so much younger than we used to. And, what kind of goes along with that, and I think makes matters even worse, is that this rise is not unique to colorectal cancer. We're actually seeing this in other GI cancers as well throughout the intestinal tract. So young onset cancers are rising in pancreas, in appendix cancers. I see a lot of appendix cancers. Many of them are under the age of 50, and this is rising. Stomach cancers, and other like neuroendocrine cancers as well. So something clearly is changing throughout our gut. It's not unique to the colon. The colon is most common. Obviously, it's most common in general. And you can see here from the numbers, we roughly doubled our numbers when we look at all gastrointestinal cancers under the age of 50. But because of this rise, and because all of our young patients have the same clinical needs that our colorectal cancer patients have, we've actually expanded our center with all the services as well as the research focus to all of GI, not just limited to colorectal cancer, with our numbers now approaching just under 1,000 patients a year under the age of 50 with GI tumors. So that's been a really important piece of our center, has been this expansion with clinical support. And as I mentioned, we're growing our clinical support team to better be able to take care of our patients. We have great established research efforts with our basic scientists, including applications for NIH funding, looking at things like microbiome, looking deeper into the tumor biology, epigenetics. Thankfully, and I'm very proud and very happy of this, we have we have great collaborations established with other centers in the United States, including Dana-Farber, whom we've helped establish their center, and are now collaborating with several analyses, including microbiome and risk factor questionnaire, which is fantastic and super important. And then as well as internationally, as I mentioned, this is rising globally. So we really need to look beyond MSK for sure, but beyond the East Coast, beyond the US, putting our heads together to try to figure out why this is happening. And then we have a number of clinical trials that are looking to address unmet needs and improve outcomes. So in terms of unmet needs, a big one that comes up for us all the time is fertility. As I mentioned, all of our patients need and deserve this conversation, but it's challenging for us to sort of give them hard data to say, okay, you need surgery, and then you're going to get adjuvant chemotherapy with 5-FU and oxaliplatin as we give our rectal cancer, our colon cancer patients. But I can't quite quote you exactly what's going to happen with fertility. We have a little bit of data based on a retrospective survey that we did, a little bit of data borrowing from the breast cancer data, but we don't actually know from our own patients with our own chemotherapy exactly what happens to their hormones when they regain their menstrual cycle. Can they have babies? Specifically in colon cancer, in the curative setting, in the adjuvant setting, but also in rectal cancer, where we use a lot of radiation and surgery. We don't know the effect, for example, of radiation on testicular scatter. So we have a protocol now looking at patients with colon cancer and with rectal cancer in the curative setting, monitoring things like female hormones, LH, FSH, what happens to them on treatment, what happens to them off treatment, and follow up into survivorship. What happens to sperm counts, sperm motility, the quality of the sperm during radiation and after radiation. And then in women as well, we've improved our radiation techniques for rectal cancer. We can move the ovaries outside of the field. We can do a lot of things, but we tell our young women that radiation to the cervix renders it incapable of carrying a fetus due to the blood vessels, the effect of the radiation and the scarring from the radiation on the blood vessels that supply the necessary blood to the uterus. But radiation techniques have improved, and so the study will also look at the blood supply to the uterus to see if perhaps that may not be the case, or what actually the effects are of the radiation on the blood supply specifically. And then today I'll talk a little bit about one of our trials looking to improve outcomes in locally advanced rectal cancer specifically. So this was a phase 2 study of induction PD-1 blockade in patients with locally advanced mismatch repair deficient rectal adenocarcinoma. It's an ongoing study that we opened in December of 2019. So the rationale behind this was that we do well with total neoadjuvant therapy for locally advanced rectal cancer. So this is in all comers, and remember, in rectal cancer in particular is quite common in our young patients under the age of 50. That's what's really rising the most. And so what we do is in early stage tumor, we give all of our therapy upfront before surgery. So that includes chemotherapy and radiation. Then we restage them, and then we take them to surgery. And the idea of this approach is really to maximize response, decrease the chances of micrometastatic disease because we're treating everything early, and improve surgical outcomes. And in some patients, if they have a complete response, we're able to actually defer surgery. It's always with the discussion with the surgeon, but there's been a lot of movement towards non-operative management in this field, specifically because of the morbidity associated with rectal surgery. Many of our patients, up to a third, need a permanent colostomy. So we kind of were one of the first groups to establish sort of the benefit of total neoadjuvant therapy. There were earlier studies going on, but we really showed that when we give all this therapy up front, which is called total neoadjuvant therapy, or TNT, you could see that our response rates, or our tumor either being completely gone with surgery or completely gone with clinical evaluation, improved from 21% when we used to give chemo radiation alone and then surgery and then did chemotherapy, to 36% when we gave all of the treatment up front. So that's part of the NCCN guidelines now, and pretty established at most centers as the standard for locally advanced rectal cancer. So we do better. However, surgery, as I mentioned, still has a lot of toxicities. Many patients experience urinary incontinence. Many patients experience sexual dysfunction, men more so than women. It's not talked about as much, but it's true. Defecatory problems up to a third, and a permanent colostomy in many of our patients that have very low tumors. And so these are not trivial. So although it is a curative procedure and critically important for our patients, it does come with significant sequelae, which affect everybody, but especially our young patients. Radiation also has its consequences. There's short and long-term toxicity of radiation. It's a negative impact on bowel function, bladder function, sexual function, which is critical for many of our young patients, reproductive function as well. Chemotherapy is important in downsizing, but also has its own set of potential toxicities, including, so the idea behind chemotherapy is that we're giving it to treat micrometastatic disease early. We're giving it early to potentially have the opportunity of maybe not radiate or maybe not do surgery. And it can actually get rid of symptoms quite early. We found actually faster than radiation. And critical, I think, here for us is that actually it can give us a clue as to who those patients are that don't respond to chemotherapy. So mismatch repair deficient locally advanced rectal cancer, or what's known as MSI-H, comprises about 5 to 10% of all locally advanced rectal cancers. So there's about 40,000 of those a year. So about 5 to 10% of those, roughly maybe about 4,000 or so cases annually. The majority of these patients do have Lynch syndrome. So they are part of our young onset patients, but these actually have a specific hereditary predisposition. Not all. So some of them are still sporadic and are mismatch repair deficient, but about 84% of them do have Lynch syndrome. And because they have Lynch syndrome, many of them are very, very young because they're diagnosed for the first time when they present with this cancer. We know that this particular subset of tumors don't respond well in the colon to adjuvant chemotherapy, so to adjuvant 5-FU alone. And what we noted, because of our total neoadjuvant therapy approach in rectal cancer, we also saw this. We actually saw that nearly 30% of these patients, when they got total neoadjuvant therapy, just chemotherapy, did not respond or progressed. And you could see that here. This was in huge contrast to our patients that have what's called mismatch repair proficient or MSS tumors, where everyone either responded or had stable disease. Here, nearly 30% of them actually were resistant to chemotherapy. So that was quite scary. And other studies have actually shown this as well. This was a study called Foxtrot, where they gave chemotherapy to patients with colon cancer that could have undergone surgery, but they gave preoperative chemotherapy and then kind of assessed response. And they saw in their subset of patients that had mismatch repair deficient or MSI-H tumors that a large proportion of them did not respond, very different to their MSS tumors, kind of supporting these same things, that these tumors are just not as sensitive to chemotherapy. But we know that this population does really well with immunotherapy. We have great data in the metastatic setting, and we had a small study in the neoadjuvant setting or preoperative setting in early stage colon cancer, where they gave it to a few patients with mismatch repair deficiency and just a few cycles, and then took them to surgery, and 60% of them had a pathologic complete response. So this was the idea behind the design of our study, where we thought, okay, this is the treatment paradigm. What if we swap out the chemotherapy, and instead of giving chemotherapy, we replace it with immunotherapy? And then we give immunotherapy for 6 months and then assess the patients. And if they have a complete response, they can undergo observation, non-operative management. They can even omit radiation. If they don't have a complete response, they can get the standard of care chemoradiation. And then if they have a complete response again, they can undergo observation. If they don't, they can undergo surgery. So the beauty here was that we follow these patients very, very closely. And if they had a complete clinical response to just immunotherapy, they can skip potentially both the radiation and the surgery. So this would be hugely beneficial especially for our young patients, but for all of our patients, where they could omit the toxicity potentially of radiation as well as surgery. So this is the design of this study. The idea basically is that we give 6 months of immunotherapy, and then if they have a complete response, we assess them, and they can be followed with non-operative management, and they can omit radiation and omit surgery. If they don't, then they undergo the standard schema. So the way that we designed the response criteria was based on published data, where we were really strict about this. We needed our surgeons to look with an endoscopy as well as an MRI with our radiologist, and it had to have complete disappearance of tumor visually, with digital exam, like a digital exam of the rectum, as well as by MRI. So very, very strict criteria for definition of complete response. Okay, so this is the study schema. I don't think it's anything other than what we mentioned, just to show you that we're doing very specific, thorough sort of assessments and careful watching of the patients on immunotherapy, with the baseline exam, 6 weeks, 3 months, and 6 months. This is the study design, and this was the response criteria. And here is the summary of the patients enrolled. So the total number of patients enrolled, 16 patients so far. 11 of them have completed all 6 months of therapy. So it's the 11 that we're presenting as evaluable. What's important here is that all of the patients had very big, advanced, bulky tumors. 94% of them had lymph node involvement. So that suggests like a later stage tumor, not, a very small tumor where we would potentially just be able to do surgery or not need to do chemotherapy or not need to do radiation. These were patients that by standard treatment, we would have offered chemotherapy and chemoradiation, and then very likely also surgery. We assessed 14 patients, and out of the 14, 57 of them, actually 57% rather, had Lynch syndrome, which is kind of what we expected to see. And then these are the patient responses. So the most important thing here is that out of the 11 patients who completed therapy, all 11 of them had the tumor disappear with just immunotherapy alone. None of them needed radiation, and none of them have needed surgery. So this is really, really, really exciting data, for us, obviously, in terms of 100% response rate, which has never been seen. But then more importantly, I think for our patients, You could see in the age range, the youngest is 26, oldest is 77, but all of them, none of them needed radiation. We have several young women who want to have babies, of whom that was, critically important. We had several patients with very low tumors who would have needed a permanent colostomy, who have not needed surgery. We're following them very closely. 4 of them have crossed the 1-year mark, so are already kind of statistically speaking in a very good place in terms of the very, very low chances of this tumor growing back. But it has been a really exciting data so far, and really nothing better than happy tears from patients and happy messages in terms of how well they've done and how well they feel, after completion of treatment. So it's been really incredibly rewarding and fantastic, and very promising so far. So that's the patients. I'll say that patient number 13 is still on treatment. He was assessed here just at 3 months, but already had no tumor. So it was, very, very exciting that he's already kind of reached that group as well, but we're not including him in the report because he hasn't completed the full 6 months of therapy. And this is a little bit graphic, but I just want to show you because I think a picture really speaks 1,000 words. So this is one of our patients, 30-year-old woman, newly diagnosed Lynch syndrome, presented with rectal bleeding, as most of them did, some rectal pain, diagnosed with this rectal tumor, and enrolled on our trial because she was mismatch repair deficient. And then we did a genetics workup and found out that she does have MSI-H pathogenic mutation and does in fact have Lynch syndrome. And this is her endoscopy. So the top of the slide is the start of Dostarlimab treatment. So all the way on the left, you can't really miss it, is a visual of her tumor with an endoscopy. So this is a rectal tumor. So the endoscopist, in this case here, our surgeons, looks in with the scope through the anus into the beginning of the rectum, sort of from the anus into the rectum. And you can see that you almost don't see what's called the lumen, or the hole that leads to the rest of the bowel up into the colon. This is all tumor. This is all very abnormal. This is treatment on Dostarlimab. Beautiful response very early on. This is just 4 months of treatment, nearly no tumor. And this is just the beautiful, perfect lining that we would expect anyone to have that does not have cancer. So completely gone. It was already gone here. This is when they biopsy. We see a little bit of blood. So that's why this picture was just taken after the biopsy, but you could see very rapid, phenomenal, just fantastic response. And there they mark the scar, which I would not have appreciated, but that's just a little scar. And that's what we see on MRI as well. And this was a year out, and this patient remains disease-free now over 2 years out from completion of therapy. So, or nearly, actually, just nearly 2 years out. So really fantastic, beautiful response. And again, sorry that it's graphic, but I really think it's really illustrates, how well this responds, how quickly it responds. And obviously you can see from this, our patients feel better really very quickly. And so no radiation, no surgery. This is just immunotherapy alone. In conclusion, with this trial, we're seeing 100% response rate so far in our patients who have completed 6 months of therapy. This is critically important for our patients as it may allow them to avoid chemoradiation and surgery. We, of course, need to continue follow-up. We need to really establish the durability of this response. And we have ongoing, very close surveillance of our patients. In the schema, it's every 4 months they undergo surveillance with MRI and visual surveillance with endoscopy. And this represents a potential new treatment paradigm based on such robust responses. And our hope is, as more broadly as part of the Young Onset Center for all of our patients, it's part of our research focus to do this, but for other patients as well, not just our patients with with MSI high tumors, but to really try to focus on improving outcomes while minimizing morbidity in all of our patients, but particularly our young patients with early advanced disease, as well as with metastatic disease. And then I think the greater goal of the Young Onset Center is to identify the patients that are at risk. We don't know how to find them. We can't screen everybody. We can't do surveillance colonoscopies, as I mentioned, in the 15-year-olds that I'm seeing, but we can maybe, our goal is to find risk factors and find those people that are at risk for whatever reason and screen them and prevent this cancer from happening in the first place. And thank you so much for your attention. I really appreciate your time and welcome any questions.
From August 20th till February 21, do you continue to have Keytruda?
No, thank you for asking that. That's a great question. Do you see the blue line on top? It's the drug is called Dostarlimab, but it's a PD-1 inhibitor, just like Keytruda, but it's a different drug. But we finish here. It's only, thank you for asking this. It's only 6 months of therapy. That's it. So this woman finished here in May and then did not receive any therapy. This was just all of this, including to now, is just observation. So we actually were, we weren't sure how long to do the treatment for, and based on some of the earlier data and the fact that this was locally advanced, we decided to do 6 months of therapy, and it really looks like that is sufficient for response. Many of our patients, we see it quite early on, but everyone gets just 6 months of therapy.
Okay, thank you for that. I think there was another question.
Yes, hi. First of all, thank you very much for this wonderful and very exciting work, and thank you for your presentation. My question is, out of those 11 patients that you had with this wonderful response, were any with mucinous tumors?
Great question. Yes, we had 2 patients with mucinous tumors, so those are quite tricky. We biopsy the patients, frequently each time that they're assessed. So at each of these, they get a biopsy, as I mentioned. So we saw disappearance of the tumor very early. With mucin, the MRIs, we discussed them with our tumor board, and they said, and if the agreement was that they were mucinous tumors, based on assessment, based on MRI, we agreed to watch them. We have a lot of experience with mucinous tumors and know that often these take a long time to regress. So 2 of those patients did have mucinous tumors, and then by MRI, there's still something there, but we know that it's mucin. But it is definitely trickier with mucinous tumors.
So when you said you had complete pathologic response, what you said that for mucinous tumors, tumors didn't actually disappear, but the biopsy didn't show any cancer.
Correct.
So.
Yeah, the biopsy, we call it, like the biopsy, right? Not that we take the biopsy with a grain of salt. We did it. I don't put too much weight into it because they just get the superficial area, but all of those biopsies were negative in all the patients. But since we didn't take any of them to surgery, we don't call it, pathologic. But yeah, the tumor was completely gone in all the mucinous patients as well.
Mm-hmm,
Yeah.
mm-hmm.
Dr. Cercek, do you want to talk a little bit about the presence of mucin and against, the finding tumor cells in it, like with the mucinous tumors?
Yeah, so, we don't know, to be honest. I think if from the metastatic setting in some of these MSI tumors, there is a concern that if it sits there, it can eventually grow, or if we don't know, or if the mucin is just dead tissue. I think that's why observation in these patients is going to be so important. I can tell you, prior to the study, sort of my inspiration for this study were several patients that I treated that had these ugly progressive tumors on chemotherapy, and then I treated them with immunotherapy, and they had beautiful responses. And I have a few that have mucinous tumors that I've watched now for years, and they're just kind of sit there where they're just slowly regressing over time. So it's still up for debate, and I know that many not many, but I should say we've had cases certainly discussed at tumor board where it looks like tumor in the metastatic setting, you know, and they have a rectal primary, they undergo resection, and then there's absolutely nothing but mucin. And everybody regrets having put these people through surgery, you know? So I think mucin gives everybody pause. We pay close attention to it. We're doing that anyway on trial. So I don't think we're missing anything or compromising the care of those patients, because we've seen so much so that you know, they undergo surgery for no reason sometimes. So it's the best we can do, I think.
Okay, so what you're basically saying is that from your clinical experience, even when you have found mucin, but no cancer, the patients seem to have good prognosis. And based on that, you're saying that this is likely to be the case here also.
Exactly. But
okay.
Exactly.
Yeah. Okay, thank you very much. And I had like one question about, you know, have you guys looked at like the link between microplastics and diet? You know, it seems that we're all eating microplastics, whether we
yes, I
not.
love that question, Manju, because it's I looked at it myself a lot. I think, you know, they're everywhere, right? I've read a lot of papers and sort of tried to find kind of preclinical things that we could look at. It's definitely a plan of mine. We don't have anything established yet, but it actually, when you really start thinking about it, you realize that they are in absolutely everything. They're in, you know, every like Starbucks cup that we drink. And I mean, just every cup that kids drink, like everything. So baby bottles, I mean, you know, everywhere. So the only thing I'll say for that, and I've thought about it a lot also because of where the tumors are located and how they happen. The only thing is we've looked at polyps in these patients and survivors, and they do make polyps, you know, so part of me thought, well, if it's microplastics, maybe it's kind of a one and done, you know, something happens, the plastic gets embedded and causes trouble, and then a cancer develops, but they do make polyps. It's not exactly, it doesn't seem exactly at the same frequency that people in their 60s and 70s, that colon cancer survivors in their 60s and 70s do, but they do make them. They make them much more than we would expect someone in their 30s and 40s, you know, so there's probably something more, but whether there's a global change or maybe the estrogens in the microplastics, not that colon cancer is, I don't want to spread false rumors, it's not linked to estrogens at all, but maybe there's some changes that happen that we just, you know, don't know about. So yeah, to your point, I think, yes, that's one of them. And like, they're all over the sea, right? They're in everything we ingest. So
they say even in breast milk.
Yeah,
so,
like, right. Yeah.
I was wondering, I know it's not quite a fair question, but if you, in your medical opinion, if you compare the Dostarlimab with Pembro, how do they compare? Is one a little more effective than the other? Are they very similar?
I think they should be very similar. They should be the same. I don't have any data to suggest otherwise. I can tell you, you know, this trial is with Dostarlimab, so I think it's fantastic. It's working really well, but we've had great success in the metastatic setting and in the anecdotal patients that I mentioned with Pembrolizumab, and so they should be the same. They're both PD-1 inhibitors, but I don't have data to tell you. You know, there's no like head-to-head comparison, and there won't be, I don't think.
Okay, and is it that for this trial, when you were designing it, this was the drug that was available, and that's why you went with it?
Yeah, exactly.
Okay,
exactly. Yeah, it was an investigator-initiated study, so.
Okay, you had to go with what was offered.
Yeah.
Okay. And then one question I have is that in MSI-H rectal cancer, you're seeing a lot of Lynch syndrome, right? Is that already known, or is there a reason why they are?
Yeah, we don't know. It's a little bit different patterns too in terms of MSH6, MSH2 being the predominant findings, mutations. We don't know why. It's been published. So we saw it in our cohort. We're seeing it now in this trial, though it's early. And it's been published by others as well, but we don't know why that is. There's no good explanation. It's just a bit more than what we're used to seeing in colon, where they tend to be more sporadic.
Okay, okay. And then I kind of wanted to tell you that we have, like in Town, we have a Town Junior group, which is for pediatric colorectal cancer. And like you were mentioning, 15, you have two 15-year-olds. Like the idea is that these polyps and things take like 15 years to grow. So
right, I know. I mean, it really makes you wonder if it's a B in utero. You know, it's just these two that I mentioned were like literally their parents are, 40 and don't even have polyps.
Okay, okay. Like
Yeah.
still completely sporadic.
Completely.
Yeah.
Yeah.
Okay. And then you had talked about a study like where they had a couple of cycles of IO and then they got like 60% of them had CR. So, like when you compare your study with like Dr. Siombar's study where she's using Ipi+Nivo and a couple of cycles of radiation, right? Like how does it compare? Like, yours, the trial schema is like 6 months of Dostarlimab, right? And
right.
do you see any side effects? Like is it kind of comparable to like Pembro, the profile of side effects?
Yeah, I think to single agent, yes, to the combination, which is what Dr. Siombar is doing and also what was done in the colon study. I think we do see more toxicity with dual checkpoint blockade. So that was a concern, for me. And now that I see that we have this data, for me, it wouldn't make sense to do 2 drugs because we're already seeing 100% response rate with just a single drug. I do think duration, plays a role here. And in my study design in particular, my goal really was to see how we could maximize immunotherapy alone to decrease the morbidity of the other, of radiation and surgery, because we know in this disease, radiation works. I mentioned, our data because the way that we sequenced it was chemotherapy first, then we did chemoradiation. So when you're taking care of these patients, we saw that the tumors were growing on the chemotherapy, which was not what we were used to seeing, But when we gave chemoradiation, they were salvaged and the disease responded and they got to surgery and they were cured, but then they had to have radiation. So the idea with this study, and I think what distinguishes it really is that it's so far we've not had to radiate anybody. We've just been doing immunotherapy alone and having 100% response rate. And so we're really optimizing, the therapy and omitting both radiation and surgery.
Okay. What about, are you collecting ctDNA and other markers?
Yes, we are. Yeah, we're in the process of analyzing that. Okay. I think the ctDNA will be interesting because we'll see, how it correlates with response and how quickly people clear it. It may or may not be helpful to sort of to guide us in terms of like the tumor being completely gone or not. I think that correlation with MRI will be really interesting. So we collected it at every point that we had endoscopic evaluation and biopsy and imaging.
Okay.
Well, I was wondering why was it chosen to do immunotherapy for 6 months initially? Why 6 months? Because I know that the studies for stage 4, their immunotherapy, I believe, was for a year initially. So why was the duration of 6 months expected to have such advanced response? Why not a longer time?
That's a great question. So I thought about this a lot, as you can imagine, because obviously the goal was still to cure. So we didn't want to compromise duration, standard therapies. I was very conscious to make sure that the patients had the opportunity to undergo radiation if they needed it, that we weren't going to give them something that's going to compromise their chance of cure. So that's why the 2-year mark in a curative setting just seemed really long. And when you look at the metastatic data in patients at the time, it was just in patients who were refractory. So who in the MSI-H metastatic patients, right, who got chemo, 2, 3, 4 lines of chemo, and then had immunotherapy that was first published by Dr. Lee. The maximal response, the time to response there was around 8 or 9 months. So we figured from that number that naive tumors, early stage, that weren't metastatic, that didn't see any chemo before, didn't have a chance to kind of become a little bit more resistant to the microenvironment, would respond better. And then also having seen some of the earlier data in the neoadjuvant setting, we thought in the colon cancer, with 60% after just 2 cycles, 6 months kind of seemed like a fair compromise to do. But it is a great question, in certain patients, should we have done more? Could we have done less? I think less, we assess them at 3 months. Many do have endoscopic regression of the tumor, not all though. So I think in the end, it was a good choice, but that was kind of the thinking, was sort of extrapolating from a bunch of different data points. And then importantly, for me to allow them, to be followed closely, and then to get that standard of care if they needed it for cure.
Okay, thank you.
Thank you.
One question. So with the bulky MSI-H tumors, the response is like a little bit delayed, right? Like usually you don't see regression right away on the scans, right? Do you want to make some general comments about your experience dealing with these kind of bulky, large MSI-H tumors?
Yeah, so that's another great point. So that was another thing and why we did such close assessment, because we thought, oh, if there's pseudoprogression or if these tumors obstruct, but in fact, they respond. I mean, you can see from this picture, the response is really quick, but you can also see, they tell us they stop bleeding very quickly after the first, it's every 3 weeks after the first or second dose. They feel better. It doesn't hurt. They stop bleeding. They have normal bowels. So it's different. It's actually different and much more powerful. I think the response faster and more powerful, it seems.
Okay, so what you're saying is that, do you feel that there's a difference when you use like neoadjuvant in the early
I do. I think it's key. I do. I really do. Yeah.
Okay, thank you so much.
Sure.
We passed the time, and thank you so much for your time and the great presentation.
Absolutely. It's my pleasure.